I'm Dr. Kamrava. I'm a dual board certified general and colorectal surgeon. What makes me a pilonidal expert? In training, really the same as any other colorectal surgeon. We're all trained and board tested to ensure that we know the most advanced techniques and treatment modalities for pilonidal cysts. But I'm one who has made a practice and has focused my practice on treating it on a day in, day out basis and bringing all the best treatments to hand and giving those options to my patients to decide what is the best path forward for them. Treatments for pilonidal cyst, there are several. The original treatment for pilonidal cyst, well, 20, 30 years ago, actually when I was a medical student, was to just cut out the cyst and close the area, which is called primary excision and closure. That fell out of favor because the specific area that pilonidal cysts occur, which is in the tailbone area, is specifically a very difficult part of the body for wounds to heal. It's multifactorial. It has to do with tension on the wounds at the cutaneous level. It has to do with hygiene in the area. It's generally an area where sweat and debris does track on the body. And it's also an area that has high motion on the body. We do surgery there and you quickly have to move around in a place that will immediately get affected by that movement. Because of that, the wound failure rate approached in many reports up to 50%. This was difficult for surgeons because they would operate on patients and half of them would come back with a wound that had ripped open. And so patients not understanding the physiologic nature of that part of the body would, logically blame their surgeon and say, you did a bad job, which really wasn't the case. So due to these challenges, the field in the early 2000s moved to what most surgeons now in the country and actually abroad do, which is to open up the wound and leave an open wound to heal, which is called unroofing. And some surgeons will also add on to that marsupialization. And that's a well-established and accepted practice for pilonidal disease. The challenge with unroofing and leaving an open wound is that it takes anywhere from 2 to 6 months to heal. And in some patients, up to 15–20%, the wound never heals. They're left with a chronic wound that is struggling and that they have to deal with. In response to these non-healing wounds, we devised flap procedures. And there's all these different types of flaps. There's the rhomboid flap, there's the kerydacus, there's Vascon procedures. All of the flaps are good, and they're good because they close the wound. And so instead of going home with an open wound that has to heal over several months, you go home with a wound that is already healed. But what they do is they deal with those wound tension problems that the original primary excision and closure struggled with. It matters less which flap your surgeon uses, and more matters that he or she was trained and is very comfortable in that flap. I, for one, trained at University of Pennsylvania. I'm very, very comfortable and have done hundreds of rhomboid flaps. So it's my primary choice when I do a flap. And for smaller cysts, I typically will use a kerydacus flap, which the Cleveland Clinic has also recommended as a good strategy as a flap technique. Cleveland Clinic, which is our kind of base for colorectal surgery in terms of studies and recommendations, recognizes the rhomboid flap as the gold standard for flap procedures in treatment of pilonidal disease. Whereas with the open wound, you had about a 15–20% failure rate. With the flaps, you're looking at about a 5% failure rate. It's still there, and it's a still real number. Even though 5% sounds small, you're looking at about 1 in 20, 1 in 25 that the wounds don't work versus 1 in 5. That's a big advantage. But still, even in the best of hands, I've had patients too, recurrences do happen, and it's a numbers game. More recently, other treatments have come into the forefront. One is an experimental treatment, not really recognized in the US, but used in South America and Europe largely, is laser ablation of a pilonidal cyst. The laser specifically goes in and basically burns the entire capsule that makes the pilonidal sinus. And the hope is by burning that sinus, you can get the area to scar through where it previously couldn't. Success rates are lower with laser than they are with the rhomboid or the flap procedures. But patients many times will opt for these type of treatments because the scarring is far less and cosmetically it looks superior to having a large flap scar. Success rates for laser hover around 80% in the reports from Europe and in our own experience. More recently, American Society of Colorectal Surgeons recommended an outpatient procedure done in the office, and it's now considered a standard practice and recommendation, and that's phenol-based chemical treatment to pilonidal cysts. The advantages of doing phenol is that it's done in the office, there's no anesthesia, and there's very minimal, if any, recovery time. 90% cure rates, so it's a 1 in 10 rather than 1 in 20, so it is less successful. So for every 10 patients, it will prove unsuccessful. But the advantages are that it requires very little, if any, downtime, very little recovery, and the cosmetic result is actually superior and equivalent to essentially the laser. Most patients in our practice these days are opting for the Phenol treatment given these recommendations. You can find me online at drkamrava.com, link below, and you can even book an appointment online. If you're from out of state, you could also book virtual appointments, and we can figure out together what would be the best course of therapy that fits your lifestyle and your needs.